I'll start the session. I'm Dr. Chalpat Reddy. I'm the moderator of today's session. And if you have any doubts, you can ask me. And I'll read out the instructions before judges. Start and conclude session on time. And duration of each paper is 5 minutes. And changing of presenting author is not allowed. Membership number up to 27,309 are ratified. Any membership number beyond that is not eligible for an award. If there are absentees, please indicate in the mark sheet. I'll do that. Please do not consult. Computation of announcement. Result announced subject to ratification by Scientific Committee Office. Thank you. And shall I call upon the first presenter? Ravali? Anapalli? Yes. This one.
Start.
The timer is, let the timer be on. Yes.
Very good morning. My topic is a comparative study of complications of subtenon versus peribulbar block in small incision cataract surgery. I am Dr. Ravali Enepalli. Financial disclosure, no financial interest. Cataract is the leading cause of preventable blindness in India and worldwide. Prevalence is 66.2%. Cataract surgeries are usually performed under local anesthesia. Retrobulbar anesthesia was popular in the earlier time, and it is lost its popularity due to its sight-threatening complications. Later, peribulbar anesthesia has become popular. In the recent years, subtenon anesthesia started gaining attention. Aim to compare the complications of subtenon versus peribulbar block in patients undergoing small incision cataract surgery. Materials and methods. Studies and observational study. 40 patients undergoing small incision cataract surgery at the ophthalmology department were selected and randomly divided into two groups of 20 each. Group A, peribulbar block, and Group B, subtenon block. Study Center, Department of Ophthalmology, Teaching Hospital. Study period 1 month. Inclusion criteria. Patients undergoing small incision cataract surgery and gave a written consent. Exclusion criteria. Patients above 80 years and sensitivity to lignocaine and previous history of trauma or inflammation or surgeries. An informed and well-written consent is taken from each patient. Detailed history is collected and a comprehensive ocular examination is done, including vision testing, slit lamp examination, fundoscopy, IOL power calculation, duct syringing, intraocular pressure is measured, and routine blood investigations are done. Preoperatively, 0.1 ml of subcutaneous lignocaine is given as test dose, and acetazolamide 250 milligrams is given the night before the surgery, and moxifloxacin eye drops are given 4 times a day before surgery and 1 hour before surgery. Ketorolac eye drops are given 3 times on day before surgery and 1 hour before surgery. Tropicamide plus drops are given 4 times 1 hour prior to the surgery. All procedures are done under strict aseptic conditions in operation theatre. Anesthetic agent used was lignocaine with 2% lignocaine with adrenaline 1:2 lakh dilution, and 1 vial of hyaluronidase 1500 international units were added to it. Coming to peribulbar block, the patient is made to lie in supine position and asked to look in a primary gaze, and the eye to be operated is cleaned with povidone iodine, and after palpating the inferior orbital rim, the junction of the medial 2/3 and the lateral 1/3 with a 5 ml syringe of 23 gauge and 25 mm needle, bevel facing the globe, is introduced, and after aspirating and no blood is found, 5 ml of the anesthetic agent is injected. Coming to the subtenon's block, the site is painted and draped, and then the operating eye is cleaned with povidone 5%, and 2 drops of the topical anesthetic agent 0.5% proparacaine are added. Then a universal wire speculum is inserted. The patient is asked to look superotemporally in order to expose the inferonasal quadrant, and the conjunctiva along with the Tenon's capsule is grasped with the limbs forceps, and a nick is made with the Westcott scissors at around 5 to 6 mm from the limbus, and a curved blunt tipped steel subtenon cannula of 22 gauge was inserted along the curvature of the globe, and around 3 ml of the anesthetic agent was injected. And possible complications like chemosis, subconjunctival hemorrhage, ecchymosis, globe perforation, retrobulbar hemorrhage were noted and documented. The collected data was analyzed. Coming to the results, in the 40 patients, about 18 were females and 22 were males, and the complications In the peribulbar group, around 11 were having chemosis, and in the subtenon, 14 patients were having chemosis, and in the peribulbar group, around 12 patients had subconjunctival hemorrhage, and 8 patients had subconjunctival hemorrhage in peribulbar, and 12 patients in subtenon had subconjunctival hemorrhage. And these complications do not interfere with the steps of the surgery as suggested by Kumar and et al. And we did not encounter any site-threatening complications like globe perforation or retrobulbar hemorrhage. So in comparison to the peribulbar, we feel that subtenon is a safer procedure as there are no site-threatening complications. And chemosis and subconjunctival hemorrhage are usually more in the subtenon, but with adequate practice and proper technique, chemosis can be avoided. Thank you. These are our references.
Why only 40 cases you have taken?
Sir, peripheral medical college, sir. Very less cases. Yes, sir. Thank you, sir.
Now I call upon Ravichandra. Slides. Excuse me.
Great. Yeah. Good morning, everyone. Today my topic is visual outcomes after phacoemulsification surgery with monofocal and multifocal intraocular lenses. It's a retrospective study. Coming to the introduction, in the recent times, the cataract surgery has become more of a refractive procedure with the primary objective being shifting from visual restoration to emmetropia. And compensating the lack of accommodation following the surgery is one of the most important challenges following cataract surgery, and multifocal IOLs have been specifically designed to serve this purpose so as to give clear, sharp retinal images at various working distances and reduce the dependency on spectacles post-surgery. However, on the flip side, they tend to reduce the contrast sensitivity and may cause symptoms like glare and halos post-operatively. With this background, I go to the aim of my study, which is the primary objective being to compare the visual outcomes following phacoemulsification surgery with both monofocal and multifocal intraocular lenses. Secondary objective being the assessment of functional status and quality of life with these IOLs. Coming on to the methods, it was a retrospective study conducted at our hospital, and all the patients between a period of 2 years duration, and all the patients underwent phacoemulsification surgery by a single surgeon under topical anesthesia, and a same multifocal IOL was used in all the patients of the multifocal group, and both groups were evaluated post-operatively at 3 weeks and 6 weeks for distant and near visual acuity, and subjective symptoms such as glare and halos and difficulty in nighttime driving were noted. Coming on to the results, 204 eyes of 204 patients were included, 1 or 2 in each group. At the end of 6 weeks, the distant visual acuity was about 6.6 to 6.9 in about 80% of the monofocal patients, and 95% of the patients with multifocal IOL. Remaining patients having 6.12 to 6.18 vision. And why is it closed? Coming on to the near vision, 95% of the patients with the multifocal group 95% of the patients in the multifocal group had a vision of N6 to N8, which was statistically significant when compared to the other group.
Timer off. Timer off.
Yes. And 18% of the multifocal group patients have complained of glare and halos as their symptoms when compared to monofocal group who never had these symptoms. And about 7% patients in multifocal group had difficulty in nighttime driving, and nearly 95% of the patients in multifocal group had become spectacle independent at the end of 6 weeks. Coming on to the discussion part, our study data showed that preoperatively majority of the patients in our study were dependent on spectacles for near vision. However, there was no statistical significant difference between the two groups on the preoperative near vision. Postoperatively, at the end of 6 weeks, the uncorrected near visual acuity was about N6 to N8 in 95% of the patients in multifocal group, which was statistically significant. And about 10 patients, even in the monofocal group, had a good near vision up to N8 to N10, which could have been explained by their longer axial lens. And these findings were supported by similar studies done by Kumar et al. And Gimbel et al. And there was one more point. In our study, corrected near visual acuity was similar in both the groups, which was also supported by a similar study by Chaim et al. The important mechanism being the visual cortex usually doesn't have the pre-wide circuitry that allows it to digest information from the multifocal lenses. So the brain requires a period of adjustment known as neuroadaptation that involves suppressing near vision when gazing at distant objects and restricting distant vision when focusing on closer objects. So this neuroadaptation could have been the reason for development of near vision, improvement of near vision at the end of 6 weeks in multifocal group, almost to that of 95%. However, 5% patients even in the multifocal group required spectacles in our study, which could have been explained by these patients requiring more neuroadaptation time or being the astigmatism induced by the surgery. To conclude, multifocal IOL experienced reduced spectacle dependency for near vision and a higher level of patient satisfaction, despite fewer complaints of halos, glare, and difficulty in night driving. Monofocal IOL group experienced spectacle dependency for near. Overall, multifocal IOLs offered better near vision, good distant vision, lesser limitation visual function in selected and motivated patients. However, multifocal IOLs can improve the quality of light in active patients who wish to reduce their dependency on glasses. Coming on to the strengths of my study, it's a good sample size, single surgeon for all the patients, same multifocal IOL used in all patients. However, the limitations being the retrospective nature of the study, shorter duration of follow-up, and contrast sensitivity was not measured in our study. Thank you.
Yes. Are there any contraindications for multifocal IOLs? Relative or?
No, it's professional drivers or architects or pilots maybe.
Is that it, or any other comorbidities like retinal pathologies, macular pathologies you do go?
Yeah, specifically the drivers and the professional guys.
No. Pre-existing comorbidities like macular, the RMD.
Yeah, we have excluded all those. Huh? Any macular pathology we have excluded.
Okay, good.
Thank you.
Next I call upon Ritu Singh. Singh is around?
A very good morning to the respected moderator on the dais and an intellectual audience here. I'm Dr. Ritu Singh and I'm here to present my talk on corneal endothelial changes following cataract surgery in hard nucleus. This is a RCT comparing phaco to a manual SICS. I do not have any financial interests or relations to disclose. As Dr. Ravali had pointed, a prevalence of 66% is present in India, and a pre-COVID consensus tells that 6.4 million cataract surgeries are done per year in our country. So it is imperative to determine which is the best visual rehabilitative procedure, most cost effective, and the safest of all. Any surgery where we enter the intraocular compartment, there is an endothelial damage, and a normal attrition rate of 0.3 to 0.5% is always present once a patient begins to age up. And specular microscopy is one non-invasive diagnostic test which can reflect upon what the endothelial damage has been done post-operatively. The research question here arises is which method is to be performed and when? Should we perform phaco for hard nucleus, or should we go about with what is already mentioned in the previous literature that SICS is safe? The aim of the study was to evaluate and compare endothelial cell loss in both these surgical procedures. It was a tertiary care hospital-based study, a prospective one with a double-blinded RCT design. The sample size was of 216, and we included all the patients with senile cataract of nuclear sclerosis greater than 3 as per the LOCS classification. The exclusion criteria were as follows: endothelial cell density less than 1500 cells per millimeter cube, any history of ocular surgery or trauma, or any other coexisting ocular disease which could be a confounding factor. This is an algorithm showcasing the consort guidelines that I had followed. The enrollment was of 216 patients, of which we excluded 17 who did not meet our inclusion criteria. We randomized 199 patients and divided into 2 arms. I'm going to skip the demographic statistics here. Here, this these are the bar graphs representing the differences that were seen at post-operative 6 weeks time. On the left-hand side is the endothelial cell density, which was post-operatively increased in both the groups, and it was significant. The central corneal thickness also increased in the immediate post-op group, but wasn't statistically significant at 6 weeks. So therefore, I studied the endothelial cell density group, and these were the 4 parameters which showed statistically significant outcomes: age of the patient, cataract grade, effective phacoemulsification time, and anterior chamber depth. The last scattered dot on the right hand side shows the anterior chamber depth. We can see an inverse relation, and that was the only criteria which was significantly statistically significant in both our groups A and B. So I plotted an ROC curve, that is receiver operating curve, and we found the area under the curve was 0.8 and a statistical significant value that is less than 0.04. We got a cutoff value of 2.86 millimeter of ACD, pointed in the red arrow, which means any shallow AC depth of less than 2.86 would lead to greater endothelial cell damage. There have been conflicting reports in many data which says that shallower anterior chamber is directly proportional to a smaller axial length, but in our case scenario, nothing of that sort was found. We have many data which say that ECD loss is comparable in both the groups, but none of the literature has pointed out in hard nuclear cataracts. So this was the first study in India which showed hard nuclear cataracts. Concomitantly, after COVID, there have been many studies on it. To conclude, the substantial post-op reduction in the ECD is associated with various factors which I had pointed in the scattered dot graphs: advanced age, hardness of cataractous nucleus, and longer EPT, out of which one criteria, that is shallow anterior chamber depth, can be used to determine which of the surgeries should we go about with. And a cutoff value of 2.86 millimeters was our final value that we could come out in the study. That can be used as a parameter pre-operatively to determine which surgery should we go about with, SICS or phaco. Thank you so much.
Was the surgeon the same or?
Yes, single surgeon, sir, double blinded. Yes, sir. Thank you so much.
Now I call upon Devanshi.
Good morning everyone. I am Dr. Devanshi. I will be presenting on association of serum vitamin D levels and age-related cataract. Age-related cataract is one of the most common cause of reversible loss of vision globally. Its pathophysiology involves photooxidation of proteins in the lens. Vitamin D helps in suppressing the oxidative stress and thus investigating the association between vitamin D and its cataractogenesis effect might prove to be beneficial. Methodology: it was a cross-sectional study conducted at a tertiary care center. The case group had patients who were more than 50 years of age, having senile cataract and not having any confounding factors such as glaucoma, previous ocular surgery, history of steroid use, systemic and metabolic disorders like diabetes, hypertension, and cardiopulmonary disease. The control group had subjects enrolled from the outpatient clinic who were more than 50 years of age, following the same exclusion criteria but with no cataract detected. Each patient underwent complete ophthalmological and clinical examination and routine lab investigations. Slit lamp was used to classify the type and grade of cataract on comparing it with the log third grading chart. The sample of 3 ml of peripheral blood was collected in a sterile plain vacutainer for vitamin D assay. Results: our cases and control groups were well cross-matched. The mean age in the case group was 64.66 years, while in control group it was 63.68 years, with the male to female ratio in case group being 51:49 and in control group 52:48. The vitamin D levels in the case and control population varied significantly. The vitamin D levels in the case group was 19.30 nanogram per ml, while in the control group it was 28.27 nanogram per ml. The relation between the type of cataract and vitamin D levels was seen, in which the levels were seen highest in the posterior subcapsular type of cataract and lowest were seen in the nuclear type of cataract. Discussion. Despite the advancements, cataract continues to be a leading public health issue which will grow as the population and life expectancy increases, especially in developing countries like India. So finding a modifiable risk factor that can suspend or reduce the formation of cataract can prove to be a cost-effective and appreciated step in the future. In our study, the mean vitamin D levels were 19.30 nanograms per ml and 28.27 nanograms per ml in the case and the control groups respectively. Although vitamin D deficiency was found to be present in both the groups, but the levels were significantly more deficient in the cataract group compared to the control group. A statistically significant difference was observed between the mean vitamin D levels and the different morphological types of cataracts. The highest mean vitamin D levels were found in the posterior subcapsular group with 24.64 nanograms per ml, followed by mixed type, anterior subcapsular type, cortical cataract, and the lowest were found in the nuclear cataracts, that was 12.21 nanograms per ml. Conclusion. Vitamin D levels in the human body plays a significant and a valuable role in the development of cataract. This strong association motivates us to start evaluating vitamin D levels in routine checkups and also further study the role of vitamin D supplements in possible delaying of cataract formation. Thank you.
Where was this study done in Lucknow?
Bikaner.
Huh?
Bikaner.
It's
Yeah.
a rural population or
A majorly rural population.
population.
Yeah.
is the incidence of vitamin D is such high in rural population where they are exposed to sun?
We had taken that, we had asked in the history that if there is any exposure, 5 hours we have taken the limit that we have asked the patient if there is any exposure to sun, 5
Age
hours.
and sex criteria are taken into consideration?
Yes.
Age factor?
Yes,
What
yes.
age groups you have seen with vitamin D deficiency?
Ma'am, sir, we have taken more than 50 years of age patients. We have enrolled only those patients who were more than 50 years of
Our
age.
observation is most of us are vitamin D deficiency and most of us doesn't have cataract till 70s, 80s.
Yeah,
And most of the women of rural folk who are exposed to sun with good vitamin D levels, they come early with cataracts.
But we had
Your study has a relevance, but what I mean is vitamin D deficiency may not be the only cause of cortical cataract or nuclear cataract. Their exposure to sun, their exposure to UV rays, and they are mostly in the harsh
climate.
climates.
Yeah.
So that could be the possible cause rather than anyway a good study. Thank you.
Thank you.
Now I call upon Hemant Ramchandran.
Very good morning to everybody. Today I'll be presenting a free paper on the comparison of the clinical and inflammatory biomarkers in dry eye disease following phacoemulsification and manual small incision cataract surgery. Then coming to the introduction, the latest definition of the dry eye disease, as per the Deuce classification, is it's a multifactorial disease of the ocular surface which is characterized by a loss of homeostasis of the tear film. And it's also accompanied by the ocular symptoms in which the tear film instability and then the ocular surface inflammation and then the neurosensory abnormalities also play etiological roles. The cataract surgery has been shown to be responsible for transiently inducing or exacerbating the dry eye disease. This study will help us know the difference between the incidence in the dry eye disease after manual small incision cataract surgery and the phacoemulsification, and it will help in formulating the new methods of prophylaxis and also the treatment. Second, then the purpose of our study is to compare the ocular symptom scores and then the Schimmer's 1 values and then the TBUT values and the corneal surface staining scores preoperatively and at the postoperative day 1 and then at the end of the 3rd week and then at the end of the 2nd month, and then also to compare the tear film inflammatory markers, that is interleukin 1 beta and interleukin 6, and then the meibomian gland changes preoperatively and at postoperative day 1, at the end of 3rd week and at the end of the 2nd month. And then the sample size of our study was 86, and then there were 2 study groups. The 43 patients underwent manual small incision cataract surgery, and then the 43 patients underwent phacoemulsification. And then the dry eye disease incidence and then the pattern were calculated using ocular surface disease index questionnaire SHIMMERS-1 test, and then the TBUT, and then the National Eye Institute staining score, and then the MGD, and then the inflammatory markers also were assessed, like in the tear fluid, which were interleukin 1 beta and interleukin 6 levels. And then only one surgeon performed all the cataract surgeries, and then all the variables were checked for the normality, and then the quantitative variables were assessed in terms of mean plus or minus standard deviation, and then the categorical variables were expressed in terms of frequency and the percentages. And then coming to the results, actually when we compared the OSDA scores, NA scores, and then the dry eye disease incidence were significantly worse in manual small incision as compared to the phacoemulsification group. Here you can see the p-value is less than 0.001, and then this is a graph depicting the same. And then when it comes to the meibomian gland dysfunction, there was no significant worsening. There was though worsening at the immediate post-operative period, but at the end of the second month, the meibomian gland functions were almost back to the normal. And then when we come to the inflammatory markers, the interleukin 1 beta levels and interleukin 6 levels remained high in manual small incision cataract surgery when compared to the phacoemulsification, even at the end of day 60. So actually the inflammatory marker levels also correlated with the incidence of clinical dry eye disease. This is a graph of the same. And then coming to the discussion, in this study we saw that dry eye symptoms and ocular surface alteration can occur after cataract surgery, thus leading to the development of dry eye after cataract surgery. And in our study, clinically the MSICS group had worse dry eye disease compared to the phacoemulsification, which also corresponded with the interleukin levels. And then this is the only study comparing dry eye disease among manual small incision cataract surgery and then the phacoemulsification by using both the clinical and the inflammatory markers. And then these are the various studies. And then coming to the limitations and the recommendations, only the normal patients were included and not the dry eye disease patients. And then the small subgroup of clinical dry eye disease was actually detected in the study population. And then the study is not actually powered to detect the differences between the normal and the DED subgroup. And then maybe future studies will be needed to evaluate the effect of cataract surgery in already pre-existing dry eye disease patients. And then the conclusion of my study is the iatrogenic dry eye disease will be caused by cataract surgery, both by manual small incision cataract surgery and the phacoemulsification. But when we compare the clinical parameters, the dry eye disease was worse in manual small incision cataract surgery group compared to the phacoemulsification, and then which was also corresponded with the inflammatory marker level being high with manual small incision group. So in case of any pre-existing dry eye disease patients with the cataract, phacoemulsification would be the better option. These are my references. Thank you.
What was the time period you followed these patients?
Sir, actually post-operatively at actually day 1 we followed, and then at the end of the 3rd week, and then at the end of the actually 2nd month, sir. Actually till actually 2 months we followed, since that is actually shorter interval.
Yeah.
We could have followed up.
Because this dry eye is more or less in the first few weeks, most of
It will be there.
every cataract patient will
Patients
have
will
some
have.
amount of dry eyes because of the antibiotics
Yes,
and
sir.
other medications
Yeah.
we use, and we do use
Topical steroid.
the lubricants.
Lubricants.
For short time after 2nd week or 3rd week in most of these meters. But
We
in
could
the long run, you have to tell
could have.
whether there is a difference in the dry eye between these two groups.
Yeah, actually our follow-up is a bit short.
Because our country we have equal number of
Lot.
phacos and small incisions, and
Yes.
if the instance is really high with the MSS, then probably people will
Shift to phaco.
But your study period is short.
2
But over
months.
time, I think unlike refractive surgeries like LASIK and PRKs, this cataract surgery, I don't think in the long run this dry eye
There will be a lot of difference.
will not have much difference. Initial few weeks,
Yes,
probably
sir.
you may be right. Okay, anyway, thank
Thank you.
I call upon Rocky D'Souza.
Can I start?
Yes, you can start your.
Good morning, everyone. I'm Dr. Aki Cruz, and I'll be representing my paper on comparative analysis of iris claw lens implantation with and without anterior vitrectomy. So the primary objective is to analyze the visual outcome, intraocular pressure profile, complications post retropupillary iris claw lens fixation in complicated cataract surgery induced aphakia, and to compare the results of retropupillary iris claw fixation in eyes with and without anterior vitrectomy. So iris claw lens implantation has emerged as one of the most safest and quickest procedure for secondary IOLs. Studies have shown that anterior versus retropupillary fixation has yielded similar results and complication profile. However, retropupillary fixation is more advantageous because it respects the physiological location that is the same of that of crystalline lens. Routinely, everybody does an anterior vitrectomy along with retropupillary iris claw lens implantation. However, few surgeons may not do that if the vitreous disturbance is minimal or it is not around the pupillary margin. So, the chances of IOP spike, secondary inflammation, recurrent uveitis and visual prognosis in such cases without a anterior vitrectomy is not studied yet. So when we did a comprehensive review of literature, we found that there are very less prospective studies on the long-term outcomes of retropupillary ICLs also. So we wanted to measure the primary outcomes of long-term visual outcome analysis and complications in retropupillary iris claw lens implantation, comparison of the IOP and the complication profile in with and without anterior vitrectomy. And the secondary outcome what we wanted to measure was the chances of IOP rise and complications in eyes with RP-ICL implantation without a peripheral iodectomy. So this is a retroprospective study started from July 2021 to 2023. We included all cases of complicated cataract surgeries with intraoperative posterior capsular rupture, sonnular dialysis with a minimum of 3 months follow-up. And we excluded all cases of primary iris abnormalities, iris new vessels, pre-existing glaucoma and uveitis. We collected all the demographic data and completely done a total ophthalmic evaluation. These are the statistic tests used. So we had a total of 36 eyes, and the mean age of presentation was 68 years. Group A, that is with the anterior vitrectomy, included 18 eyes, and Group B without anterior vitrectomy also included 18 eyes. Mean best corrected visual acuity was 1.6, which improved to 0.33 at 3 months. Mean IOP was 15 millimeters of mercury. So the BCVA improved significantly in both the groups, and there was no statistically significant difference between the two groups. Post-operative IOP was highest on day 1, and the mean was around 22.6 millimeters of mercury, but it has reduced to 14.2 millimeters of mercury by the end of 3rd month. An IOP greater than 21 millimeters of mercury was noted in 10 patients in Group A, that is with anterior vitrectomy, and 11 in Group B without anterior vitrectomy, but the difference was not statistically significant. Group B eyes did have a high rate of postoperative transient IOP rise, recurrent iritis, pupil ovalization that Group A, but the difference was not statistically significant. Disenclavation of iris claw lens happened in 1 patient in Group A and 2 cases in Group B, which were re-enclavated later. Complete ICL dislocation into the posteriorly happened in 1 case, which was then referred to a VIA surgeon, and pars plana vitrectomy with SFIOL implantation was done in that case. So primary surgical PI along with the retropupillary iris claw lens implantation was done in 14 eyes. A secondary laser PI was required in 3 cases post-operatively in those which were not done due to uncontrolled IOP. However, there was no statistically significant difference noted in the IOP profile between the two groups with or without PI. So there are various studies which says that iris claw lens implantation is comparable to other SFIOL as well as ACIOL and all, and this has a much easier technique and with a much safety profile. A study by Madhivanan et al. Has said that in retropupillary iris claw lens implanted patients, incidence of iritis, transient raised IOP and ovalization was higher, but in our case it was safer and a simpler method with a good visual outcome. So till date, there are no studies comparing the retropupillary iris claw lens implantation with and without anterior vitrectomy, and our results shows that there is no increased IOP and complications without an anterior vitrectomy if the vitreous disturbance is very minimal. And retropupillary iris claw lens implantation is routinely performed along with the PI. But there are no studies on the specific need of the PI and reports on IOP rise. So we conclude that if the lens is properly implanted respecting the anatomy of the lens with a deep and formed AC following implantation and a round pupil, the chances of IOP rise and further complications are less even if you don't do a routine surgical PA, and if there is IOP rise, you can do it later. Thank you.
Yes, you have done a good study, but retropupillary iris lenses, the lens is vaulted, and
Sir,
which type of lens did you use? Vaulted one or a flat one? PMM lens?
actually, we have used the vaulted one.
Vaulted ones only. But in spite of that, anti-vitrectomy, thorough anti-vitrectomy, and peripheral iodectomy is a must before you, when you implant a lens, and then the peripheral iodectomy should be away from the enclavation area, and all the patients you should have done anti-vitrectomy before implanting iris claw lens, and there is no excuse for that, and this cannot be compared also. And in fact, you know what are the complications of vitreous in the anterior chamber?
Yeah.
Endothelial decomposition, raised IOP, all those things. So you have to refine your technique, not the comparison. There is no comparison between those two. And once you want to implant a retrofixated IOL, you have to do thorough anti-vitrectomy. Were these cases done primarily or secondarily?
All primary cases.
All primary, on the table.
We have actually did not do anterior vitrectomy only in those cases where the vitreous disturbance was minimal. Like if there is no vitreous in the AC.
But in spite of that, though it is minimal, you have seen IOP spikes.
Minimal IOP is 22
Minimal
million.
IOP spikes. So that means to say you have to do vitrectomy irrespective of the amount of vitreous disturbance. If you see vitreous disturbance, you have to do anti-vitrectomy and then put. Why you put iris claw lens, not a sulcus IOL? Because the capsular rent is so big, or you don't have a support. Okay, anyway, good study, and you thank you. I call upon Purnima. Purnima.
Good morning, everyone. I'm Dr. Purnima. I'm here to present the case titled Breaking the Gel by Laser Brought the Vision Back. In this presentation, I'm going to tell the non-invasive method of dealing the vitreous at the pupillary border after cataract surgery by anti-ag laser. So, capsular axis extension to the periphery is a common occurrence, mainly because of intumescency of the lens or due to the white cataracts. The incidence of posterior capsular rupture was 0.2 to 14%, and the rate of vitreous loss is 1 to 5%. Delayed vitreous loss can also occur, the most common reason being the placement of IOL in the sulcus. And the consequences of vitreous loss, as we already know, pupillary block glaucoma, and due to that there will be raised IOP, corneal decompensation, and posteriorly there will be cystoid macular edema and retinal detachment also. So even if the vitrectomy machine is not available, we can easily terminate the vitreous at the pupillary area by anti-ag laser. We are reporting the management of vitreous at the pupillary area after cataract surgery by anti-ag laser. I'm going to present a 54-year-old lady with a chief complaint of diminution of vision in the right eye since 6 months. Vision is hand movements in the right eye. There's no history of ocular trauma or ocular surgery. So we are planned for right eye small incision cataract surgery and PCIOL under local anesthesia. Intraoperatively, PC rent was noted, sponge vitrectomy done, IOL placed in sulcus, everything went well, and wound closed with 10-0 nylon. On the first post-operative day, vision is 6/18 due to mild corneal Descemet's folds, and IOL is in place. So we discharged the patient with systemic antibiotics for 5 days, topical steroids, topical cycloplegics, topical antibiotic drops, and asked her to review after 1 week. On the 7th post-operative day, her vision is 660 due to clump of vitreous at the pupillary area. In the first picture, you'll be able to see there's a shallow AC with corneal edema, and in the second picture there's a clump of vitreous at the pupillary area. So on the same day, we planned for right eye YAG vitreolysis under topical anesthesia after taking informed consent from the patient. So anti-YAG vitreolysis done with anterior focus with 2 millijoules of energy. Here you can see the post-operative pictures on the day 7 and 1 month after YAG vitreolysis. The cornea is clear and the AC was deep. the pupillary area was completely cleared of the vitreous, and the patient is now enjoying 6/9 vision. And patient is being followed up for post-laser IOP rise and cystoid macular edema for 3 to 4 weeks, which was not there. Post-operative laser care, we are given topical steroids and topical antibiotic eye drops. There is no post-laser IOP elevation, so we did not prescribe any anti-glaucoma medications. Conclusion, YAG vitreolysis can be used successfully to lyse the vitreous at the pupillary border. As it is a non-invasive procedure, the complications associated with the second surgery are invariably eliminated. These are my references. Thank you.
Okay. How many cases you did? You have shown
One
case.
case.
One case.
Yes.
Yes. Actually, after if you have a vitreous loss or if you expect vitreous to come into the antechamber, we don't dilate. But we've been using cyclopentolate twice, and you can increase the steroids and you can add anti-glaucoma medications.
Yes,
But
there is no
should be
post-laser IOP rise, so we did not added anti-glaucoma medications.
yeah, but immediate post-op. You
Yes,
have
sir.
dilated the pupil and more vitreous will come out.
Yes, sir.
So if the pupil is
So,
small,
IOL is in place, sir. In the sulcus, it is in place. So, we thought we can add cycloplegic, and we have added.
yes. Okay, thank you.
Thank you, sir.
Professor Arvind Kumar.
Respected judge and my dear friends, so my study is on a randomized trial between Moria's technique of nucleus hydroexpression versus viscoexpression in manual small incision cataract surgery. So cataract surgery has evolved from an ECC to M6, phaco, and now flax and robotic surgeries, and all surgical procedure has a complication rate, and the goal and challenge for ophthalmic surgeons are to minimize them. Elective cataract surgery is associated with some endothelial cell loss, which is of particular concern as endothelial cells cannot regenerate. And in phaco, 8 to 25% loss is there, and M6, different studies have seen that 4 to 16% is there. And there are various studies comparing M6 versus phaco, but none had compared different steps of manual small incision cataract surgery. So this was the first prospective randomized trial to analyze and compare the endothelial cell loss during M6 using the viscoelastic assisted nucleus removal versus Moria's technique of nucleus hydroexpression with basal salt solution. So the demography, uncorrected distant visual acuity, and BCVA post-op, pre and post-op IOP, changes in CCT, and pre and post-op changes in keratometry at day 1 and day 90 were evaluated. So this was a prospective randomized trial of 204 patients, single surgeon M6 using viscoelastic assisted nucleus removal and versus the Moria's technique at a tertiary eye care hospital. Inclusion criteria: more than 5.5 mm of mydriasis, no central corneal opacity, no previous surgery, ECD of more than 2000 mm square, group A nucleus removal using OVD, and group B using Moria's technique. So this was a design of our patented hydrocannula. So this is how it looks. So it's a 3-way beveled up cannula with the one central hole, large hole, and 2 sideways, smaller hole. So this is again a video showing viscoelastic assisted removal of the nucleus, and this is using the Moria's hydrocannula. Using the basal salt solution. So these were the results. The mean age of the patient was 64.5 plus minus 8.2 year, and in both the groups there was no significant difference in the demography. The mean logmar visual acuity for both groups on day 1 and day 90 was statistically significant with p-value of 0.001 in both the techniques. Now we come to the change in IOP from the pre-operative to post-operative day 1 and 19 group was 0.7% and 8.7%, and group 2 was 2.7% and 7.5%. Endothelial cell loss of 9.7% and only 4.8% in the Moria's technique of nucleus hydroexpression with a significant p-value as we compared both the techniques. And pre and post-op CCT K1 K2 there was insignificant p-value in both the techniques. So in discussion, iatrogenic surgical trauma to endothelia result in PBK and a gross reduction in visual acuity, and previous studies had compared ECD loss during phaco or compared between phaco and SICS. So we compared 2 techniques of nucleus removal using OVDs and Moria's technique. This prospective randomized trial proves that like during PCIOL implantation, BSS plus can be used for nucleus delivery with less endothelial cell loss of only 4.8%. And IOP also decreases up to 7 to 8% after M6. This was not noted, this was an accidental finding in our study. And the IOP decrease was noted till up to 1 year. So in conclusion, as per our knowledge, this is the first large-scale analysis highlighting the pachymetric IOP and endothelial cell changes during the nucleus removal by two different nucleus removal techniques of small incision cataract surgery. Thank you so very much.
What was the size of your incision, sir?
Sorry?
What was the size of your incision tunnel?
Tunnels is 6.5 to 7.5 depending on the nucleus. All temporal incision, as seen in the video.
Topical, peripheral.
Subtenum.
Subtenum, sir.
Yeah, subtenum. In few cases we use intracameral
How
also.
different is this from Blumenthal technique?
Blumenthal, yeah, because they are using the anterior chamber maintainer. So we are using three-way hydrocannula, so it maintaining the chamber also as well as prolapsing and it is curved. So there is no trauma to the tunnel. This is the advantage. Yeah.
May I call upon Salu Chandran? Dr. Salu? It's not around. Next I'll call upon Kamala. Mukkamala, Dr. Mukkamala. Sir, last session. We have three or four more papers.
A very good morning to respected one and all. Today I am going to give a talk on a study of contrast sensitivity in eyes with hydrophobic and hydrophilic acrylic foldable PCIOLs. There are no financial interests or relations to disclose as a part of my study. And coming to introduction, the cataract extraction techniques has evolved over the years. However, despite a cataract surgery with successful IOL implantation and adequate refractive outcome, patients often complain of visual field side effects. So, the contrast sensitivity may be decreased following IOL implantation. This may be related to the optic design, dimensions, spectral transmission characteristics, and optical qualities of the intraocular lens. So, coming to what is meant by contrast, contrast can be defined as a degree of blackness to the whiteness of a particular object. So, contrast sensitivity is the ability to perceive sharp and clear outlines. A patient can have 6 visual acuity with loss of contrast sensitivity. Sometimes the loss of contrast sensitivity is more psychologically disturbing to the patient than the loss of visual acuity alone. And the need for the study is the visual acuity tested by Snell lens is very high contrast, but in the reality, the patient can get visually handicapped because there is no amount of high contrast in the outside world. So the contrast sensitivity is considered as a better predictor of visual acuity as it provides information not provided by the visual acuity alone. So in my aim, I will evaluate the effect of IOLs on contrast sensitivity function following phaco surgery, and the objectives are to compare the effect of foldable aspheric hydrophilic acrylic PCIOLs with hydrophobic acrylic PCIOLs following uneventful phacoemulsification surgery, and we will compare the contrast sensitivity before and after cataract surgery. And this is an analytical observational study done with the duration of 3 months, and total of 50 patients were taken who underwent successful in the bag PCIOL implantation, and we divided into 2 groups. The group 1 receives hydrophilic aspheric PCIOL, and group 2 receives hydrophobic aspheric PCIOL. And patients with the cataract up to grade 2 to grade 3 nuclear sclerosis were included in the study, and only the patients who have underwent successful in the bag PCIOL implantation with post-operative vision more than 6/9 are included, and harder cataracts and mature cataracts and patients with regenerative conditions of the macula, that is ARMD, and patients with other ocular pathologies which will significantly reduce the contrast sensitivity were excluded from the study. And preoperatively, we have evaluated for best corrected visual acuity, contrast sensitivity using Pelley-Robson's chart and corneal curvatures, intraocular pressure, and anterior segment, posterior segment examination along with B-scan, axial length and IOL power calculation. And post-operatively, we have done contrast sensitivity function using Pelley-Robson chart with best corrected spectacle vision after 4th week. And the statistical analysis for intergroup comparison, we have done independent sample t-test, and intragroup comparison, we have done pair t-test, and p-value less than 0.05 was considered statistically significant. And results show that cataract extraction will have significant improvement in the contrast sensitivity, and in the hydrophilic IOL group there was significant increase in contrast sensitivity before and after cataract surgery, similar with that of hydrophobic IOLs, but there was no significant statistically significant difference between the two groups when compared in the intergroup comparison after posterior chamber intraocular lens implantation with no significant p-value. And coming to discussion, usually cataract surgery will improve the contrast sensitivity. There are optical qualities and optical spectral domain characteristics like AB numbers which represents the chromatic dispersion of the material, and higher values of this represent lower chromatic dispersion. So hydrophilic IOLs have higher AB numbers, so low chromatic dispersion. So and hygroscopy is the ability to observe and hold water. This is also high in cases of hydrophobic IOLs when compared to hydrophilic IOLs and compared to hydrophobic IOLs, because hydrophilic IOLs will bond with the water molecules, whereas hydrophobic will repel the water molecules. So these glistenings are also common in hydrophobic groups, and compared to glares, and glare disability is also common among the hydrophobic groups. But these properties have no significant impact on contrast sensitivity in patients regardless of the material of IOL. There was increase in contrast sensitivity post-operatively. A study by Anthony Chang also demonstrated the same result, concluded that after 9 years, even though more glistenings are there in hydrophobic IOLs, it has no significant impact on contrast sensitivity. And also the Ackman et al. Also concluded the same, and the limitation is more sophisticated measures are there other than Pelley-Robson chart, and mesopic conditions are not measured in this study. So in both the groups, regardless of the material of IOL, contrast sensitivity function increases post cataract surgery. Thank you. These are my references. Thank you.
Pradeep Kumar Mahanta. I call upon Triveni, if Triveni is not there.
Good morning, one and all. And today I am going to present a comparison of central macular thickness in non-diabetics versus diabetics in post-cataract surgery. Financial interest nil, and cataract is an important clinical problem affecting in all patients. Globally, the diabetic population is on the rise, as number of cases is expected to increase up to 72% to 333 million by the year 2025. And both types of diabetes mellitus are associated with an increased frequency of cataract surgery. For patients with diabetes mellitus, CME and exacerbated diabetic macular edema may adversely affect visual outcomes after cataract surgery. And optical coherence tomography is an established ophthalmic diagnostic tool, particularly for macular and vitreoretinal interface disease such as age-related macular degeneration, macular hole, and diabetic retinopathy. And this technology is a non-contact, non-invasive technique for in vivo imaging of the retina. And we are able to compare central macular thickness changes before and after cataract surgery between non-diabetics and diabetic patients without retinopathy using OCT. And the objectives are to assess changes in central macular thickness pre and post-operative cataract surgery in non-diabetics, and pre and post-operative cataract surgery in diabetic patients without retinopathy, and to compare the findings between both the groups. And this is observational study of sample size 50 patients done in tertiary care center of duration 6 months, informed consent taken and institutional ethical clearance taken. And we included patients undergoing cataract surgery for senile immature cataract LOCS 3 grading and patients diagnosed to have diabetes as per ADA criteria without diabetic retinopathy, and we excluded patients with traumatic cataract, mature cataract, and patients with pseudoexfoliation, patients with a complicated cataract, and any pre-existing ocular retinal pathology that could affect the macular thickness. And demographic details collected, all the patients underwent a comprehensive ophthalmic evaluation. Preoperative macular thickness was measured by OCT, and all the patients underwent uneventful SSES with PCIOL implantation performed by a single surgeon, and postoperative macular thickness by OCT measured after 6 weeks. And the statistical analysis, the collected data entered in Microsoft Excel 2010 and analysis using SPSS software. Statistical analysis, descriptive statistics were documented, and paired t-test used to compare pre and post-operative central macular thickness within each group, and unpaired t-test used to compare change in CMT between normal and diabetic patients, and p-value less than 0.05 considered to be significant. And the results are the mean CM2 value increased in both non-diabetics and diabetics post-operative 6 weeks. And they also increase in mean CMT value in both post-op non-diabetics and post-op diabetics. And in this study, there is an increase in central macular thickness in SSES following SSES seen in both the groups. And other studies like Kartika et al. Study concluded that subclinical and transient rise in central macular thickness after cataract surgery in both groups, and this is significantly higher for the manual small incision cataract surgery group than phacoemulsification. And other study, AIOCMTC2 et al. Study concluded that in diabetic eyes, minimally invasive cataract surgery could induce increased inflammation as indicated by aqueous flare, which was accompanied by an increase in macular thickness. And other study concluded that central macular thickness increased after uncomplicated cataract surgery both at week 1 and week 6 post-operatively in both diabetics and non-diabetics. And mean central macular thickness has increased in both the groups with respect to preoperative values following SSES, and this has minimal impact on postoperative visual acuity. And SSES surgery itself was found to be associated with increase in CMT to some extent. And my limitations of this study are it was relatively short postoperative duration over which patients came for review. It is possible that if follow-up had been longer, the results may have been different and smaller sample size. And these are my references. Thank you.
Good, thank you. Shall I call upon the last speaker, Tejashwi? Sir, after this. Yes, right, please.
Good morning, I am Dr. Tejashwi. The topic of presentation is immediate sequential bilateral cataract surgery, the first study of outcomes in phaco versus manual SSES. So the aim of the study is to evaluate safety and outcomes of ISBCS by both phaco and manual SSES methods. So the data was collected retrospectively from June 2020 to December 2022, and the study was conducted in a tertiary eye care center in Tamil Nadu. The patient selection is very crucial in performing ISBCS, where we included patients with visually significant bilateral cataracts in both the eyes with best corrected visual acuity worse than 6/12, and age more than 30 years were included. And the exclusion criteria, patients with the conditions that predispose to intraoperative complications like PC rent, and post-operative complications like infections, corneal decompensations, retinal detachment, CME, and in eyes with extreme axial lens, and specular microscopy where low endothelial cell count is present, and in eyes with ocular comorbidities that require a combined surgery. So we did a thorough preoperative examination. We used Lenstar and Barrett Universal 2 for IOL power calculation, and in eyes with mature and dense cataracts, we used immersion biometry and SRKT formula. It is paramount to follow the very stringent intraoperative protocol to achieve safety and success in ISBCS, where we used separate gloves, drapes, gowns, tables, trolleys, viscoelastics, irrigation lines, and we used separately fully cycled autoclave instruments for each eye. And at the end of the surgery, we gave an intracameral antibiotics. So three experienced surgeons were involved in this study, and all the intraoperative and postoperative complications and outcomes were documented. So in this study, we had 1,306 eyes, where 742 eyes were done by phaco method and 564 manual SSES. So post-operative residual spherical equivalent at the end of 1 week within less than 0.5 is excellent with 94%, and at the end of 1 month it is 96%. In either of these procedures, we achieved the targeted post-operative refraction, and there is no significant difference between both the procedures. So the intraoperative and the post-operative complications we had in our study are PCR, striate keratopathy, post-operative iritis, CME and iris prolapse, which I will discuss. Coming to discussion, the major concerns in performing an ISBCS is the risk of vision-threatening complications like bilateral end-off or bilateral CME, bilateral RD. In our study, the chief intraoperative complication we had is PCR, which occurred in the second eye. So whenever PCR if occurred in the first eye, we deferred the second eye surgery on the same day. We had 5 cases of PCR where in 2 eyes there is no vitreous disturbance, so we placed the IOL in the bag. In 3 eyes we did an anterior vitrectomy, and a 3-piece IOL is placed in sulcus with optic capture. So one patient had a bilateral CME who is a non-diabetic, and it's resolved with 2 months of treatment. There are studies saying that their mandatory use of post-operative NSAID drops to prevent CMV, which will delay in visual rehabilitation. And 12 patients had a bilateral striate keratopathy, and 23 patients had a unilateral striate keratopathy, which resolved with treatment. And 1 patient had bilateral prolonged iritis, and 1 patient had unilateral iritis, which also resolved with 2 months of treatment. So one case of SSES, we had a iris prolapse where we did a iris reposition and suturing. So this is a comparative analysis of complications in previously published study, where our present study was comparable to previous studies. There are no sight-threatening complications such as end-off, retinal detachment, corneal decompensation, TARS or intraocular hemorrhages. So out of 1,306 eyes, we had 30 eyes with more than 0.75 diopter of spherical equivalent. In all these eyes, there is a pre-existing astigmatism which was not addressed. So this is the comparative analysis of visual outcomes in previously published studies. Our study is comparable to previous studies with excellent outcome. So thus both the FACO and SSES exceptionally brought satisfactory outcomes in terms of achieving targeted refraction. So in conclusion, this is the 6th largest study that was done in ISBCS globally, and also this is the first study to be done by manual SSES method. So the safety and outcomes of ISBCS was comparable to that of a single eye surgery when done by strictly adhering to the patient selection criteria and following the perioperative recommendations concerning each eye as an individual, autonomous and a new procedure. These are my references. Thank you.
What is the instance of endophthalmitis in the country?
So it's bilaterally it was less than 0.002 it was noted.
Not bilaterally.
Unilaterally it is less than 0.05.
That means to say in 1,000 cases, how many cases do you expect?
Maybe
0.05%.
it will be less than 2 or 3 patients.
5 patients.
5 patients, yeah. Yes,
So your study you have done about 1,000 cases, and
yes,
5 patients will, if the.
Sir, when we follow,
I understand. You did not have, but it's not for take home, and you have done it on diabetics also.
Yeah.
So if there is there a necessity for doing sequential bilateral sequential?
Yes, sir. There are indications where we can do.
Indications are there.
Yes, sir.
Pediatric cases.
Pediatric cases we can do where they require general anesthesia.
You have included all general population.
Yes, sir. When we are doing bilaterally, when we are doing few procedures, FACO, why can't we do SSES also? It is practiced since 1952.
Not the question of SSES or FACO. Sequential, simultaneous bilateral cataract surgery in our country with incidence of 0.05% endophthalmitis, as you say. Still,
that is why the selection criteria we have to be.
Go for these things.
Yes.
Take home message is that, but of course, your study they have.
Yes, sir.
So we finished this things, and now we have a keynote address by
Dr.
Ravi Ranjan.
Yeah, very good morning. Now from cataract to lacrimation, I am Dr. Ravi Ranjan. My topic is bumpy roads to failed DCR made smooth, no financial relationship. And as published in various journals, success rate of external DCR is 85 to 97%. In spite of excellent success rate, there are failure due to all these. My aim is to assess the success rate of repeat DCR by small changes in surgical steps. and a prospective uncontrolled interventional study consisting of 134 patients from March 2011 to the 2021. All the surgeries done by a single surgeon to minimize the outcome bias of surgical experience, and incision were made on previous surgical scar. Intervening in the fibrous scar tissues were excised, and roughly 1 to 2 mm of lacrimal sac around common canaliculi was shaved, because it is always difficult to get sufficient flaps for mucosal anastomosis in repeat DCR, so that the sac remains as a disc with punctum in its middle similar to a funnel. And 10 mm Arugaz bone trephine was used, and ostium in the this is the process of making ostium in nasal bone, and this is post operative. This is a nasal packing. Just remaining at a part of the sac was sutured with subcutaneous tissue, periosteum of the middle side. The skin was opposed and sutured on 5th post operative days. Syringing of 1 ml 0.4 milligram per ml mitomycin C in newly formed passage. These all cases were followed up for 1 year, and this is a nasal endoscopy after 1 year of has, and this is a nasal opening. Yeah. The all cases were followed up on 5th day, 1 month, 3 months, 6 months, 1 year up post operatively. At each visit, the surgical outcome was assessed anatomically, which was defined as patency of the newly formed passage on syringing, and functional success was defined as tearing assessment using Monk score, and the result of 134 patients over 10 years is 131 patients were successful. At the end of follow up period, that is 12 months, 2 patients complained of PP4A of grade 2 or more, and STKI despite successful syringing and patent newly formed passage, and 1 patient failed in syringing. Thus, our anatomical success rate is 133, that is 99.2% in repeat cases, and functional success is 131, that is 97.7%. And for the comparison of the studies with previously published studies, a meta-analysis were performed using MedCalc software, and this is comparison of success rate with previously published and our and this is our result. Forest plot depict that the study by Wu et al. Can be a source of heterogeneity, and the meta-analysis of success rate shows significant heterogeneity. Our p-value is less than 0.001%, and that is very much significant, and the symmetrical funnel plot suggests absence of bias. We conceptualize this method to overcome the problem and make the repeat DCR easy to perform with successful result with short learning curve. And changes we made is use of Arugaz bone trephine, approximately 1 to 2 mm of lacrimal sac was shaved around the common internal opening, and 1 ml of 0.4 milligram per ml mitomycin syringing in newly formed passage on 5th post-operative day. We used 0.4 milligram per ml mitomycin because this was the safest and most effective dose in literatures, and we used mitomycin syringing on 5th day because it so that we can use antifibrotic property of mitomycin C maximally, as it is not diluted by bleeding from nasal mucosa, and better coincides to early proliferative phase of wound healing, which is start from 4th to 5th day of tissue injury. And just in conclusion, we can say this method is easy to perform with reliable and comparative results, needs no costly instruments, can be used for mass surgery. Okay, this surgery is not for them, but this is a boon for the masses, and thank you. Thank you.
That concludes the session, and the next session, the results will be announced by the scientific committee, and the next session will start.